co-head of school, Professor Trish Hafford-Letchfield. And Trish is going to talk about the important topic of thinking about suicide in later life. This is a key research area for Trish, who also focuses on sex and aging, LGBT issues, creative social work, pedagogy, leadership, management, and organizational development. Trish is an incredibly busy person, and she has over 100 publications, has attracted a significant amount of major research funding. And before Strathclyde, as Professor of Social Work, Trish was Professor of Social Care at Middlesex University. And Trish really is a prime mover in bringing about change in a range of areas, and we're very, very lucky to have her here at Strathclyde University. Just before I hand over to Trish, just a few words about process. We are recording this session, so if everybody can turn their sound off for the duration of the presentation, that will be very helpful. For questions after the presentation, and we'll take these both verbally and via the chat function on Zoom. But just to reassure you that we will turn the recording off before we start taking questions. So it leaves me to hand over to Trish.
Oh, thanks, Barbara. I hope everyone can hear me well. So thanks for the opportunity of being able to discuss this topic today. I've only actually been researching in this area for a few years before the pandemic, but, you know, with the pandemic, it's absolutely highlighted the issues for people in later life, given their experiences around mental health, the impact on their mental health, and also the structural ageism that we've witnessed during the pandemic towards older people in our society. So my aim today is to give an overview of the issues, and I'm going to share some of the key messages from the literature and I'm specifically going to share how conceptualizing suicide in later life can provide a framework for thinking about how we engage and intervene when working with older people. I'm also going to focus in on one of the areas within that framework is what we call death hastening behaviour in later life, and I'm going to illustrate this with a case study from our own research, which I did a few years ago, which explored the phenomena of giving up or turning to the wall in care home settings. And finally, I hope to conclude with some key messages of what this might mean for future research, policy and practice with older people. So just two things before I go on. The first is to acknowledge members of the teams that I've worked with who've contributed to all the research that I mentioned during this presentation. Since 2018. Overall, we've conducted 3 systematic reviews and 4 empirical studies on various aspects of suicide and ageing, most of which I won't be covering today, but also to acknowledge our peer researchers with lived experience who've worked with us in the qualitative studies, and their insights and contribution have been absolutely invaluable in understanding this challenging and sensitive topic. So secondly, to remind people of some of the resources available to support people affected by suicide. And there has been a study that's shown that as many as 135 people will know each person that dies by suicide when accounting for those who are either exposed, affected or bereaved. And many of us in this webinar today will have some experience, and we need to know where to direct people who might want to get more information and support. So if you decide to leave the webinar, I completely understand if it triggers off any feelings for you. But do take note of the support available. So according to the World Health Organization, nearly 800,000 people die by suicide every year, and the highest rates of suicide worldwide are recorded in older adults. This is usually measured per 100,000 population, with suicide rates over twice as high in those aged 70 plus, where there's 27.8 per 100,000 compared to those aged 15 to 49 years, which is 11.73 per 100,000. And these increased rates of suicide only appear to decline after the age of 95 for men and the age of 90 for women. It's quite hard to really unpick and find out in detail the suicide rates, mostly because suicide in later life doesn't get recorded as well. Obviously, in the global south, global north, you know, our focus has been on those younger populations, and so I was really talking about this more globally. But the high rates of suicide observed in older people might be a consequence of the age group exhibiting more determined and planful suicide acts, coupled with fewer warnings of suicide intent. And the United Nations and World Health Organization, its Sustainable Development Goals have prioritized a coordinated response to suicide prevention. And it is an urgent public health matter. And for older people, there's so many complexities in how it's conceptualized, theorized and recognized and responded to. So in the UK, you might know that suicide prevention strategies are developed and implemented by the devolved governments of its 4 nations. And so we're interested in how developments in ageing and suicide research could provide opportunities for further steps in translating the knowledge and the process for suicide prevention and intervention. And I've put up the one for Scotland and the one for England, which I think is on its fifth iteration in terms of reviewing how the suicide prevention strategy is making progress. Actually, I wanted to just say that earlier this year, we did conduct a scoping review to take a snapshot and map how current strategies inform and serve people in later life. And what we did was a documentary analysis of the 4 national strategies in the UK. And we specifically looked at 58 suicide prevention strategies from local authorities in England and followed up with a consultation exercise with 22 key informants from third sector organisations and some of the leads responsible for suicide prevention strategies in England. And our aim was to sort of look at what sort of initiatives are in place, what issues and gaps are being developed, what sort of strategies and service provision for suicide prevention and post-prevention in later life are being developed in the UK. And I think we've just started to report on this. So we've written a paper and we'll be submitting it soon. I think it's fair to say that we identified some evidence of how suicide in later life is beginning to be addressed. And most of the strategies did state commitments and gave some examples of suicide prevention and post-prevention support. However, it is fair to say that overall we really need much more awareness and recognition of older adults' needs. And this certainly came up in the consultation. And their circumstances are yet to draw on the research evidence in the context of diverse ageing population. And the unique features of suicide and ageing. So just in summary there, that we do need a more nuanced approach to suicide prevention and post-prevention for those who are ageing. And as we will see, they're not really accessing services, or services are not really targeting that population in their provision. So in terms of theories of suicide and ageing, the literature's highlighted a high level of overlap in concepts and terminology and gaps in our understanding. It is a growing body of research, and this is because the risk factors for suicide ideation behaviour in later life is multifaceted, and we know that these are related to gender, age, mental ill health, particularly major depression, which we know is a significant problem. I think it's 20% in the community, 40% in care homes. Major stress and life events, loneliness and limited social connectedness. These are all issues we know affect the older population. And also people who have got a growing area of challenges with problematic substance use in later life, and chronic ill health. And where chronic ill health affects a person's independence. Sensory loss is a really big issue in suicide research, and all of these contributory factors highlight the complexity of identifying the full breadth of suicide-related behaviours in later life, and how to develop an understanding of how are these being expressed. And of course, we use a life course approach, and we know the growing use of trauma-informed approaches are becoming much more important. And we found this in a qualitative study that we did this year of the experience of being bereaved by suicide in later life, because bereavement by suicide is a high indicator or a high risk factor for suicide in the bereaved person themselves. And we did look at that this year, although I won't be talking about that today. So bridging this knowledge to practice gap is really important for us to think about what is going to work in prevention and what's going to help us as professionals working directly with older people on the ground. One of the things we also did in the last year was we did a scoping review and narrative synthesis of the literature on ageing suicide research, and we developed from that this conceptual framework to try and help organise thinking with a view to articulating how these concepts, bringing them together in a framework, might frame a realm for engagement with older adults towards better understanding of what informs suicide prevention intervention. So just to briefly go through these, because I'm really going to focus more on the third concept, which is the death hastening behaviour. So the first concept really concerns a sense of completed life and existential loneliness. And so, that we have been able to identify through research older people's experiences of the notion of feeling disconnected, anxiety about the future that might entail further loss of self-determination and self-sufficiency. And a lot of studies have shown that older people might refer to a life that's been lived, having a sense of completed life, and in balance with life as a burden, particularly where there's been a loss of something they've enjoyed doing or feeling, a loss of their own sense of value, sometimes a feeling of tiredness, and in some cases a feeling that they're in the process of losing themselves. And this can often arise in the context of caring for older people towards the end of life, and can be associated with negative feelings being expressed, emotions and moods such as sadness, hopelessness, grief, meaningless and anguish. And what's interesting is in the research is that people who were expressing these experiences did not necessarily fulfill any criteria for clinical depression. And some studies have articulated various theories on how this idea of existential loneliness or sense of completed life can tip into or develop into a wish to die, either a passive wish to die or an active wish to die. What we can deduce is that this can be triggered by life events or a sense of perceived burden that's not acceptable. And some people specifically talked about the hurt caused by a lack of interest in them as a person, and where this was addressed, if through any interventions, that the decision to end their life was stabilized. So positive experiences are really important here. And one other message from literature is that establishing trust is essential to help people in these existential situations that might lead to developing to death wishes. And ultimately, for us to have the time, the ability and courage to take up such difficult subjects with them. And because we know from care, it's easy to go in and see to all the practical tasks. And it takes courage. And, you know, people say don't upset the old people. When we do research with older people, we approach organisations asking to talk to, helping us access older people to talk to them about suicide. Say, oh no, we don't want to send that out because that's going to upset them. We don't want, which is, you know, absolutely patronising and denies them the opportunity to talk about the issues that concern them in their life. So that brings me on to the concept of death hastening behaviours, most of which originate from studies on what we call voluntary stopping of eating and drinking. I think you might hear about VSED. And the debates within this body of literature draws on ethical considerations, particularly in the case of advanced directives. And I think there's been a lot of talk about that, hasn't there? Particularly during the pandemic, this came to the surface. And issues which you can imagine are extremely complex, particularly when we start getting into issues of mental capacity and cognitive abilities. So in summary, this death hastening behaviour can be differentiated between refusing care and as a result of illness, a specific condition or lack of motivation to improve one's life, as well as an explicit desire to die where the person lacks the means or opportunities to do so otherwise. So it's a more of a passive type of suicide behaviour. And I'm not going to talk about self-destructive, self-harm behaviour, that's for another time. So it's this that third concept that I really wanted now to illustrate more in a case study of some research that we did on the concept. We called it giving up in care homes. This study was stimulated by a one-day conference on suicide and ageing a few years ago with practitioners and other stakeholders working in care homes and hospitals who talked constantly on the day and extensively about their experiences of working with people with death hastening behaviour and what they called it giving up or turning to the wall. And anytime I speak to anybody in the public, everybody recognises this concept or have known somebody. This is an area that people felt really helpless in knowing what to do or what they should be doing. And we know that moving to a care home is a major transition where cumulative losses can pose risk to somebody's mental health. And if we don't recognise this vulnerability can lead to depression, which extends to suicide ideation and behaviour in the form of self-harm and self-neglect. And care homes are a significant place of care until death. We know, it's been called the last refuge and all of those terms that we use to describe it, yet there is a discourse of silence, which means that self-harm and suicide may be underreported or not attended to, and even worse, not given the specialist expertise as perhaps it might do in the community. So I found this slide. I thought I will share it because I was a bit obsessed a few years ago in looking at how it was reported in care homes, and I got onto the ONS so many times. Can you look at it this way? Can you look at it that way? Because actually, if you look at this slide here, it tells you the number of deaths by suicide that have happened in care homes, and actually there's 9. In 2011, there's 9, it was 5 in 2016. There's no point in looking at it in more contemporary years because, we know it's such a skewed effect of what's happened, the devastating consequences of what's happened in care homes as a result of COVID-19. But for me, it really seems at odds of what I've heard from people on the ground. It just didn't make sense. So that's another reason why I wanted to look into it more. And we also, one of our systematic reviews, we did look at what interventions, what is the prevalence of mental health in care homes, what interventions are used in care homes to respond to mental health. And in short, we found that there are very few interventions being used at the time that I think we published this about 2 years ago. and that most of these were either project type, sort of short-term interventions. So we don't really know what works and sustains in a more sustainable way, but there is definitely a lack of guidance and instruments that are tailored for this very unique population, and that a lot of the interventions were tended to target staff awareness and education, staff how to recognise mental health, and or looking at residents' occupational needs. So, I mean, we don't have occupational therapists generally in care homes. I know that because my daughter did a placement and it was quite a unique experience. So we don't really know what works either, even at the, and certainly none of the interventions really did address self-harm and suicide in care homes. So we decided to explore this concept of giving up from the perspective of care staff. I have done a study, which I'm still writing up, of family carers' experience of when their loved one gave up. I don't know why I haven't finished writing it up yet. I found it quite distressing, a lot of the data, but I am working on it now. But in this, I just wanted to share with you the study we did on the perspective of care staff working in care homes. And what we're really interested in was their everyday communication and hidden knowledge concerning what they think about this taboo topic and the context that it reflects. And so the study design was descriptive and it's an exploratory study, and we recruited and trained researchers with lived experience. And there were 3 broad research questions that we framed to facilitate an inductive approach to gathering the data directly from the staff working in care homes who we thought were capable of throwing light on this topic. So you can see the research questions there. And in terms of our study design, as I said, it was co-produced. We thought, how are we going to get staff to talk about this issue? And we developed a vignette. But what we found is we started off with a vignette, and within 2 seconds, they weren't interested in the vignette. They were off telling their stories. So we did 4 focus groups with a total of 33 staff across the 4 care homes. I've given a little bit of information about the Care Quality Commission rating and all of that. But basically, most of them were people who worked directly with older people in care homes. And without exception, they all recognise this type of scenario in their care home and were very, very keen to talk about their experiences. So this is just some of the, I'm now going to just finish off by talking about some of the things that they found. So what they described was an individual going through a very distinct period of withdrawal, which did not always appear to coincide with the onset of any specific illness or deterioration in their mental health. So sorts of examples, a person would stop eating, talking, slowly withdrawing, making very clear statements, I'm ready to go now, what's the point of living? They describe people as really going down, you know, that was their time and that was it. Some people became very angry and aggressive over their circumstances and, you know, made very clear their behaviour to assert their power and identity, you know, leave that tablet there, I'll decide when I'm taking it. And this is just one of the quotes from one of the carers, and talked about the determination of the older person who won't get out of the bed. The family said, I can't actually read it now because all your faces are in the way, but they're saying they were, you know, very charming and really lovely, and they felt very warm towards them. Often the person would talk about the circumstances in which they came into the care home, how they didn't want it, how they felt neglected or given up on themselves. You know, very, very moving statements. The second thing that we looked at, just lost my notes, was how staff articulated how they responded to older residents who they recognise as entering or being in the phase of giving up. And these range from the provision of diversionary, distraction activities. Come along, let's go and let's go for a walk, or let's do something to divert them. And in a way, a sort of denial as well. And resistance, to actually engaging with the person, what the person was saying. And both to themselves, and to the person, or through silence, avoiders, and giving a false reassurance. And there was also lots of examples of sensitive and tender caregiving acts and expression of deep compassion towards the person. And I think it's important to contextualise this and how long the person had been living in the home, the sort of relationships that they had with staff. And this quote is somebody who really embodied what they felt the person felt like. So they said, I've had my friends now and I'm here with strangers. I don't know who they are. I'm here with people who have to look after me, yes. When I was in my own home, it would take me 2.5 hours to get myself washed and dressed, but I did it myself. Here, somebody is washing me. It could be somebody who could be my granddaughter's age. It's a lot to take on board when you go into a residential home. So embodying in how the empathy, trying to understand where the older person may be coming from. And, and also the recognition that the person's coping with multiple losses, their independence, health, partners, family, the network of friends and neighbours, because as we know that very few people have visitors, sustained visitors over a long time, care home. Some people don't have any visitors. People feel uncomfortable about visiting people in care home. They don't know what to say. They don't feel they've got any news. The older person has got any news, and then, of course, there is the whole thing about the resources that the care home has, how visible it is in the community, whether it's got an open door, etc. So what happened? The other thing is we wanted to know what happened. What did staff do when these situations occurred? So, staff definitely expressed an awareness of processes and procedures that they should follow when an older person was noticed as being depressed, withdrawn, and showing any manifestations of deterioration in their mental health. And it's something that they did refer back to their team leader or manager for further investigation. Surprisingly, they didn't say that resources was a main barrier in caring for people in these situations. And there was a lot of strong evidence of how they worked together in a team around the person to try and make space for one person to, respond to the person. So the sorts of things they talked about was talking one-to-one and spending time with individual residents, building or capitalising on any special relationships, as I said, distraction and giving space and showing respect, encouraging their families to visit in order to maintain a sense of connection, recording changes in their mood and behaviour and referring on to senior staff and sometimes specialised services. So here the manager says most time staff try to prompt him to divert attention. We never accept that fact. Oh, okay, get on with it. No, we'll try to get them out to see football, a TV show, to catch up on other things. We offer them a cup of tea. This is a strategy we always use. And there was lots of conflict between families and the care home staff. And I think the care home staff felt quite out of the loop when they followed procedures to get people assessed by GPs, by psychiatrists, mental health social workers. There's a lot of performativity, I think, around being seen to be doing something rather than being with the person, particularly if the person was refusing care, and there'll be conflict between the family and the person, and the care workers about what they could do, what they should do. Which, the tensions are like going with the person's wishes, as well as showing respect, as well as making sure that the person, safety and basic needs were met. And the other thing is they were quite distressed. They described quite a lot of situations where people were admitted to hospital when they knew the person did not want to go to hospital and died, and felt very distressed that people who they'd known and cared for a long while, when they did give up, ended up dying in hospital without the opportunity for them to care for them. I think there were quite a lot of issues around meeting the person's spiritual and religious needs. Some people, as we know, people do feel uncomfortable about sharing religious beliefs in care homes, and some people would feel that if they did bring in the priest or the minister or whatever, this was almost giving permission to the person. And then others, felt it was a really good vehicle, for connecting the person to somebody who they could discuss their end of life intentions or the feelings that they were expressing in a very, in a very accessible way. And most of all, staff talked a lot about their own distress and loss associated with these situations. They said they never get used to it. You find ways of dealing with it, but I never think of this job, that this is their last stop before they go to heaven or wherever. You don't think of the job like that. And they also felt that when things did step up, if the GP or psychiatrist came in, they would feel like they weren't part of the caring team, that this was often taken out of their hands, and that they had a lot to contribute, in continuing to care for the person. And they felt that it kind of had this bit of kind of risk assessment. Obviously it is a risk assessment, but they felt that the risk overtook their normative caring relationships. So they felt that they could be involved more in those situations. So in summary, our findings paint a complex picture. It highlights tensions in providing the right support and creating a space to respond to such challenging situations. And that when we have these scenarios where people are giving up, it really does require a very skilled and detailed assessment to respond to the risks, alongside improved training and support for paid carers, and also to support the person in, what they want and what they need to happen. And, a much more holistic strategy which capitalises on significant relationships within a wider context. So some of the reflections and recommendations from this particular study was that we need to maintain and review research and knowledge about depression, self-harm and suicide ideation behaviours impacting on older people living in care homes and hospitals, to understand and predict risk better, and to understand mental health in the context of the institutional environment, because none of the studies that I've looked at address the organisational institutional environment in which these situations occur. And there's a lot to be said for that, I think, and in order to develop appropriate and applicable prevention strategies. We also need to increase standardisation of recording suicide behaviours. As I said, everyone's got a story to tell, but if you look at the statistics or records, it's just not being collated or understood. And care has to fully understand the extent of giving up or this death hastening behaviour in care home residents, and to start to think about better ways of responding. We need to know more. I think I said earlier about being brave and engaging conversations. We need to know more about what we can do to promote and sustain people during interventions. And most of all, in all of the studies that I've read, there's very few studies that actually include older people themselves. And also paid carers, family carers and community-based professionals. So I think I'm nearly there with finishing, but I just wanted to just say that we are onwards and upwards trying to develop more of a program of research in relation to suicide and aging. As I said, at the moment we are talking to lay older people about what they think about why older people might have suicide thoughts in later life, and who they might talk to, and why they might, and you know what they think would help to talk about it and access help. So we've been talking to lay older people, and I've had some lovely emails from people after the interviews just saying, this is the first time anyone's asked me about this, and it's really been really good to talk about it. We do face barriers in accessing older people, as I said, particularly at this time, because I think people are really afraid for older people's mental health. So we need to think about that. And the other thing we've been doing is that we have done another review of all the tools that are used currently with older people. They've picked out 6 that have been evaluated in studies that have been used to screen older people around suicide ideation behaviour. So what we've been doing after the interviews is asking people to look at 1 or 2 of those for a structured questionnaire. We've been asking about, what do you think about the questions? Because are they holistic, you know, are we asking the right things? Who should ask it? What about the language? What's missing? You know, what are your thoughts about it? So we're gathering up some feedback about the common tools that are used, because people have tried to address tools over the last few years that are more holistic and do pick up the issues and concerns of older people. Some of those things that I talked at the beginning of the presentation about, you know, these existential areas, the burden, you know, feeling the burden, and also to highlight more the reason for living. Reason for living, it's very important that we focus in on motivation, reason for living, and that we build on those strengths that will help people improve their suicide thoughts and behaviour. So that's what we're doing at the moment. I'm currently trying to get some funding. I've had lots of failed funding this year, so I'm going to keep trying there. I think I do have a few things about what can we learn from this area. So I'm hoping that I've shown you that we need much greater awareness, research, prevention, intervention strategies to address suicide in later life, particularly in response to what it might look like, given that it does look differently. It's a lot in common with suicide research, but with other suicide prevention with other groups, but it does look, there are some unique features of it in later life. And to acknowledge that this is less visible and can interact with ageism and other institutional discrimination. So we need a more holistic approach as well as targeted approach. That, it can amplify struggles already known that people face when aging. And that there is an onus on us to talk to people, engage with their situation, and provide support with suicide thoughts and link them to the right support. And I think it's, again, just to remember that the life course approach, what happens to us in our lives, our journeys, are all really important and ageless in a way. So we need to think about it from a life course approach. So I think at these events you're supposed to plug your own book, but on this occasion I'm going to plug this book by Rory O'Connor, which I read a few months ago. It's been out this year. It's an absolutely beautifully written, accessible book that for the public and other people, professionals and researchers, which really is a journey about suicide research. And I was trying to look at it through the lens of aging. It's a beautiful book and has got lots of information, advice, you know. So if you're ever worried about anybody, I'm not saying buy it for Christmas, but I would say it's a book that everyone can think about their own attitudes and thoughts, and it's really challenging about what we think about suicide. So, you know, please do read it. And finally, some references. Oh, this was one of my emails that I got, if I've got a minute, that I got the other day from somebody who had one of our interviews, who joined in one of our interviews. You know, and it's very much like, oh, you know, I think this email really particularly picks up on those triggers that can actually tip people over the edge. You know, when you just can't get support, you just can't get help, and there is going to be a lot of that in the next few years. You know, sometimes feels, what is the use of carrying on? And I think this is a very important thing, you know, a point when we think about aging. There we go. Thank you.